And now we're just trying to get to it. All right. So we are live as of right now, I think. Yeah.
Mhm.
Okay. So, hi, everyone. Welcome to Cannabis and Healthcare. I'm your host, Drudys Ledbetter. I'm a nurse, a leader, a strategist, and the founder of Mac Consulting. Now, I created this series essentially because I was having a lot of issues finding a lot of information to integrate cannabis in clinical practice. And I started having siloed conversations and decided we needed a place to have this conversation all together and at the same time. So, our patients are already here. They're coming to the hospital. I'm a patient. I walk into the hospital and I have a medical card. And I think the healthcare system can't afford to keep looking away. So, across the next few weeks, I'll be sitting down with healthcare policy leaders, public health leaders, cannabis experts to just talk about what we need to do around patient safety, clinical workflows, documentation. I think most importantly, operational readiness. So, thank you for being here. Be sure to subscribe, turn on notifications. If this conversation resonates with you, you probably want to pre order the book, Healthcare Cannot Manage What It Cannot See, to really join us in the conversation about what we need to build and what healthcare needs next. So let's get into today's conversation. I am super excited to have Dasheeda Dawson with us. She is known globally as the Weed Head, and welcome, Dasheeda. She is one of the most respected voices in cannabis policy, in cannabis education, and system strategy today. She's a Princeton trained molecular biologist, an award winning strategist, and best selling author. Former founding executive director of Cannabis NYC, where she helped build New York City's legal cannabis ecosystem from the ground up. And today she serves as founder of the Weed Head and Company, and board chair of the Cannabis Regulators of Color Coalition. So I want to say that your work continues to shape the conversation around equity centered care, cannabis policy, public health, and education. What a lot of people don't know about you is that you've also been in science for a long time with your molecular biology degree, and you understand cannabis from every angle: science, policy, business, and regulation. And most importantly, community, because that's
Mhm.
really how we've connected. You've been leading this conversation for years, and I am excited to have you here today to tell us about your journey and to tell us what your thoughts are and perspectives are now that Schedule 3 is right in front of us. I can't think of a better person to join us as we kick this off. So, welcome to Schedule 3, Health Equity and the Healthcare System We Need to Build. Dasheeda Dawson, welcome.
Thank you. Oh my goodness. Congratulations, Drew, on the drop of this reference book. It's like I think shout out to you in terms of just really making history on trying to do the right thing and leading the way as a health professional that's active on both the cannabis community, but also in the actual health professional community. So you're closing a gap. I really love that. I think that's what I aim to do when I sought out professional roles in the cannabis space, creating my own. It was like, where are the holes? And do I have the skill set to fill it? And thankfully I did. I always say that feels very serendipitous, divinely led effort, because all of the things that I do well and that I care about have kind of found its way into this ecosystem of the industry. And I feel really strongly about making sure that it's successful. But it can't be if it's inherently medicinal and the health professionals and those who are the stewards of medicine in our society don't understand what's happening. So,
Yeah. Oh my gosh. I'm so glad you're here to kind of help us open up this conversation because it's important. And I think that where I want to start today with you is where people are right now. April 23rd, there was an executive order signed. Medical cannabis is Schedule 3. It's all over the headlines. There has been both excitement and a lot of skepticism around Schedule 3. So I think a lot of us are thinking, the political framing is out there, the legal framing is out there, the fiscal tax framing is out there. But what about the patients besides organizations like the Drug Policy Alliance and Americans for Safe Access, there's not a lot of people talking to clinicians and patients and operators. So I'm going to ask you, like, for my audience, what does this actually mean, the Schedule 3 situation?
For everyone's sort of day to day, not a lot has changed in the sense that if you have someone in your family that's been arrested for cannabis criminalization in the past, this designation change or order didn't get them out. You're not going to go pick them up, right? If you are still dealing with immigration related issues, and there's very many in like New York City where I'm from, whether it's yourself or someone again who is related to you and cannabis is any way involved, this rescheduling didn't change that you're going to have an uphill battle in terms of dealing with immigration and cannabis related suspicion, even not even a full crime, if you will. So overall, not a lot has changed. Rescheduling is still criminalization, just rebranded. And it's just important to note that it does reset the clock, though, on the ability to enforce against how cannabis is being used as in even in state license dynamics. But I don't want to be all doom and gloom. It's important. Like lately I've been saying salt and sugar look the same, but we know they don't taste the same. And it's like, I don't want to, have salt presented and try to convince people that it's sweet. And so I always start off with, this is salt. Right. And so this rescheduling isn't doing what it needs to do. And that's why we still have to push for descheduling, which will really open the floodgates. But I will acknowledge that what it looks like can be definitely taken as wins that are moving the needle. The first thing is, it's the first official time that the federal government is saying cannabis has medicinal value, because as you know, being designated Schedule 1, it means no medicinal value at all or medicinal use. That is kind of hilarious because in 96, California was the first state to legalize with medical legalization efforts. And then in 1998, the Federal Health and Human Services actually secured a patent on the neuroprotectant properties of cannabinoids in cannabis. So we've known for 30 years that cannabis is medicine in some capacity, and it's just been a further trickle down with almost 40 states now having some sort of medical framework. But we didn't take along the health professionals. And so in some ways, it almost didn't matter because the top docs, if you will, the people who were in charge of health and human services, it wasn't until the Biden administration that just passed nearly 50 years later that they actually said, hey, we're recommending to the DEA that this needs to be rescheduled down from 1 to 3. And so the DEA is in some ways, and the Trump administration, continuing a process. But what they did was, rather than take the whole category and reschedule it, they have separated it in a way that's artificial, and basically said, if it's an FDA approved drug, which we all know about, those are most of the pharmaceuticals that we deal with, if not all of them. And if it's an FDA approved drug with marijuana in it, it's Schedule 3, effective immediately. If it's also a product of any kind coming from a state licensed medical operator, it is also Schedule 3. But everything else, that includes all of the adult use markets that we've created in Massachusetts and New York and Maryland. The East Coast is really lit up with equity-centered adult use at that. Those are still Schedule 1, at least until we have this hearing. And with the Schedule 3 designation, it absolutely gives a pathway, to your point, for insurance, for a better understanding of how to use it in health settings, health professional settings, medical hospitals, and the like. It's been a mixed bag for me personally, and maybe a pathway to teaching this finally in medical school and nursing school, so it doesn't feel as scary. Right. But I do want to just be clear, like, again, it's still salt. I try to lay out all the things. It's the facts of what it is. And then let people take away, does that sound good or bad to you? The last thing I'll say is we are on a pathway, knowing what has already occurred, to eventually pharmaceutical entrance into the cannabis space, which makes me see cannabis now potentially as being dispensed as a pill largely, when we know it's a plant. And so there's a lot of mixed feelings here, but I think we've got to take the good, the bad, and the ugly and decide, okay, how do we push forward with the good, and make inroads.
No, thank you for that clarity. That's so important. I think one of the things I try to think of, especially because I am in healthcare every day, is that policy doesn't live on paper. It just
Right.
doesn't. Like, it shows up in access points, it shows up in clinical education, as you mentioned. It shows up in who gets protected and who gets included and who benefits. And hence why that separation of the plant theoretically makes no sense to most of us. But I'm thinking of two things right off the top of my head as you were talking is what conversations are the people who are kind of qualified, right? The people in the state medical programs. What conversations should they be having now that they weren't having 6 months ago when this was still technically illegal? And then what do you see as the biggest opportunity, especially in terms of bridging the health equity gap with Schedule 3 to move the conversation forward in a meaningful way for that population that has taken advantage of their health medical program and does get covered by this blanket executive order?
Well, state agencies, for the most part, as I talk to them through Cannabis Regulators of Color Coalition, um, they've been kind of going all along as business as usual. And I think largely because we've gone unbothered by the DEA. In 2011, the Cole memo was issued by the Obama administration, his first administration, and essentially saying if you're using it under these state licensed medical frameworks, then we will not use any resources to come after you. But the first Trump administration actually rescinded this Cole memo. So since about 2016, 2017, we haven't been under any protection in that regard. And I use the word protection because it's protecting state models from DEA. We've seen a lot of different responses based off of how the state's framework is set up. In a state like Florida, where it's only medical, their response is, as it makes sense, that this is a great thing, right? We have these opportunities to now make it accessible through all of our pharmacies, all of our various other outlets. The people who are already leading there are the ones who are leading the charge for this effort of only calling out state licensed medical operators anyway. So Florida, Pennsylvania, if you are a patient there, you may see more rapid movement and integration perhaps of those products into various spaces that you could put a DEA registration. I'm not saying gas station now, right? Like, a gas station is still not it and is not going to be it under DEA. And we could talk about some of the impact of hemp too, because it matters. It's all one plant. But far as like where a DEA registrant could be to be able to really dispense and administer prescriptions of a Schedule 3 substance, there's plenty of them. And Florida's, I think, going to move the fastest to take advantage of it. If you're somewhere where they just kind of got medical for the first time, like a Louisiana, some of these southern states that are still figuring out, they're probably more still on the side of what is the enforcement, what is the kind of way to still keep this relatively oppressed, because we don't got that yet and we don't have to get it yet. And so that's the little concern. So it's still state by state, whereas in California, the adult use licensees are dual licensed. And so what we're seeing is a lot of those, including equity licensees there, start to figure out how do they transition and play. Many have already gone through the DEA registration. That should tell you something, because again, you said May 23rd, April 23rd. And so we've been just over a month, and already in 10 days, really, they had an application portal up. That never happens, the government, without some level of collusion, pre-discussion. But yeah, every state is going to still respond differently because it didn't get descheduled. The federal government allows for states to kind of manage how they're managing controlled substances, as long as they are following the general federal cover. A conservative state like South Carolina has done nothing. It's going to still do nothing but arrest people. A more progressive conservative state like Florida has only got medical. Now you may actually be very surprised at how it starts to infiltrate. They're the best look. Whereas in a state like New York or Massachusetts, where we've done this effort to get justice impacted folks involved as operators, well, we've got a little bit of risk to figure out on behalf of those operators. And I also think that we need to really start to be in alliance with the health professionals there, because I do believe we have the most progressive health professionals in states like that. People like yourself who are like, oh no, we can't lose this. It has been helpful. Now we have our way to show how it's integrated with an equity lens. And so I'm really looking to Maryland, New Jersey, even Connecticut, crazy as it sounds, because they didn't define equity the way I would have, but Massachusetts, Rhode Island, like we have an East Coast border that has to try to figure out cannabis is inherently medicinal. We know it doesn't matter whether it's the medical route or the adult use route. It actually, like, we can't, like, government can't control how a cannabinoid acts in the body. And we know that. So how do we take up arms with our progressive health professionals who have already started thinking more plant medicine, naturopathic, more holistic anyway? And this is just part of it.
No, you are so on the money. As you're talking, I'm thinking about Massachusetts, where I'm from, and how we have just passed some like changes and adjustments to our own laws, where we are going to be duly licensed or have the ability to be duly licensed in terms of adult use. Our retailers being able to service medical patients. And at the same time, we have big out of state money from Virginia, the SAM group, trying to shut down the adult use market with this crazy ballot campaign to restore marijuana policy. Really confusing and using language to like deceive people. The way that they got the signatures was questionable. We've been really fighting. And one of the things that our team's done and our nonprofit has done is start to collect the data. And we saw that adult use is servicing 80% of therapeutic users, AKA patients. They're not necessarily using our medical program. And a lot of those communities are our communities, the communities that were already disproportionately impacted by the war on drugs and impacted by prohibition. So I heard you say risk, and risk is such a buzzword for me in healthcare. Where do you still see the risk in our communities and the communities that have already been underserved and disproportionately impacted? What is the potential in risk present if healthcare policies don't catch up and healthcare leaders are not intentional? And the reason I'm bringing the healthcare systems into this is because we already have, especially in Massachusetts, we have a priority to bridge health equity gaps. The Department of Public Health published a report last year that showed that that was our biggest issue in a healthcare rich state, in a research rich state, in an academia rich state. It's really disheartening to see how we're just not even talking about this in healthcare in any capacity. And as a leader, I keep seeing the risk. Like, a patient walks in tomorrow that has a canister of cannabis edibles in their pocket, and it's part of their medication, and they have a medical card. And I have no way of really understanding, operationalizing, documenting. My nursing staff has no idea what to do with it. I remember this summer, one of my nurses goes, "Can I get high by touching the canister?" And I was like, "What? Like, we're clinicians. This is a little wild, right?" But where's the risk if we don't start to have these conversations in healthcare? What's the risk for our communities in particular? We've already been disproportionately impacted. Like, what do we need to start doing or moving towards now to minimize that risk?
I think your example is a perfect one of what happens when we have ignorance generally. We always veer on the side of the more stereotypical or stigmatized perspective. And so the biggest risk is ignorance leads to racially biased decisions that ultimately impact people's livelihoods, whether their lives, period, right? Like we've seen it in so many different sectors. And I think in medicine, whether it's Black maternal health, Black maternal fetal health, right? Like we're struggling already. And I think all this does is add on a layer of potential stigma still attached to the plant and not a lack of knowledge, a layer also of where did they get this? And now the DEA in this order did very clearly say, if you are a patient and you give your cannabis to someone else, you're committing a crime. And so is the health professional also required to report that would we normally do that if we just see someone have a pocket full of some sort of other pharmaceutical? Probably not. I think we would decide maybe based off of other presenting factors. But I think whenever you have to create a subjective decision based off of these different factors, when there is ignorance, like complete ignorance, like if I touch the canister, will that make me high? Unfortunately, I think our communities are the ones who are bearing the brunt of that ignorance, because it bears on the side of just what's been, put in media, again, what's been stereotyped. And so I think the way we course correct this is, now that this is already at least in a realm of FDA approved and the state licensed, because there are quite a many states that have a medical program, now is the time for administration, for both the schools as well as the hospitals, any training institutions, to start looking at curricula, to start looking at books like yours, to say, how do I make sure that at the very least the next generation of people that we're graduating are entering into a market understanding cannabis as Schedule 3 at the very least. And that to me means more than reading a few PubMed articles that are slanted largely because funding has been primarily in the United States based off of the negative impact of cannabis as opposed to the positive. I want to shout out the state of New York as well, Office of Cannabis Management, because their medical lead team has done the work to create a clinical study. They're doing an IBS clinical study, irritable bowel syndrome. If you're watching, you don't know what IBS is, at least in the medical world, but that is amazing, because it is one of those things that intersectionality across different race, culture, genders, it does present differently in gender differences or sex differences, but I think at the end of the day, it's something most people can relate to. Someone maybe that has IBS, and the ability to demonstrate its cannabis effects on IBS, it opens up the door for a lot of other gut related issues, which we know, other countries know this has a greater many positive impacts. That alone, the pharmaceutical impact is huge. It's huge. And I think that's where we fix it. We start to see regulatory offices double down on the research, and the administration for hospitals and other training institutions, schools, double down on the education piece, because you have a straightway now. You shouldn't be talking about, okay, well, if we talk about this, even, are we going to lose our federal grants, which were real conversations I was having with some of the leads here. And so that smoke and mirror is gone, even though, by the way, never been an enforcement action against any of the states or any state level administrative agencies related to cannabis in 30 years. Never seen one yet, but that was still the holdup. Well, it's not a holdup anymore. Let's run.
Yes. No, and I hear you and I feel you. And as we're talking about the pharmaceutical impacts, I personally know people that have irritable bowel syndrome and have been positively affected by cannabis, and literally that is their tried and true medicine.
Absolutely.
I know people who have been weaning themselves off of seizure meds for years with cannabis and walk into the doctor. The doctor's like, why haven't you taken your seizure meds? And they couldn't have talked about their cannabis consumption at the time either, because there's this fear of disclosure and what disclosure actually means and what gets documented in your medical record.
Right.
There's a story in the Effective Cannabis newsletter. The founder, Debbie, talks very publicly about how she fought for 10 years to get cannabis abuse disorder off her medical record and what it impacted in terms of healthcare and health access. There was recently an article published by the Americans for Safe Access, about somebody who was taken off a transplant list because they had cannabis use documented in their medical record. And the contradiction in all that is that the cannabis was kept them alive long enough and well enough to be able to get on the transplant list. Right. And it's these stories are the ones that kind of stick to me like glue. But one of the stories that I actually start the book with this story because it was the most impactful from outside of stigma, right? We know that there's stigma. We know that there's health equity issues, but there is a real need for healthcare to have awareness about cannabis as a medicine. And the story I always start with is our veteran patient who was started on Coumadin, which is a blood thinner. And I haven't been in the industry and haven't been a nurse for over 20 years. In that moment, did not know that there were med interactions. So when this guy started bleeding, we didn't even think cannabis. We were sending him out to the hospital for bleeding in his urine. We were sending him out to the hospital for bleeding under his skin, trying to adjust the blood thinner medication. And it was like on the fifth ER visit that happened to be a resident in the ER that said, "Hey, have we checked the tox screen? There, sounds like cannabis is interacting with the med." And that's how we found out. And when we had the conversation with this patient, he was like, "I'm a veteran. I will lose all my veteran benefits and my insurance if this is in my medical record. Do not put it there. I don't care what it means." But what it really meant to us as clinicians was that we didn't know where the bleeding was coming from. We didn't have the information to kind of flag the risk in the medication co-exposure. And I've since learned that you can go on drugs.com and put CBD or cannabis and see there are over 400 med interactions that exist. And as a clinician, I've been screaming that from the top of my lungs because of my own experience. But then I think about how many other people have not identified cannabis as a co-exposure risk because we're mixing it with everything. People are mixing it with alcohol. They're mixing it with their antidepressants. They're mixing it. They're taking it in really high doses. And there is a risk. And I know that most of the adult use market doesn't talk about the negative impacts of cannabis because we're like, we just got in the room, right? We just started telling a positive story. Research has done a really good job at painting the negative story. But I think in terms of safety and access, we need to start thinking about putting the same kind of warnings we have on like antibiotics. When I pick up my antibiotics, it says, "Don't drink alcohol when taking this pill." There's nowhere on any medical cannabis products that says, if you're on blood thinners, you probably shouldn't be taking this, or to consult your physician. And I believe that the bridge between the Department of Public Health and our pharmacy leaders, as well as our healthcare leaders and our regulatory bodies, that they needs to be some sort of working group to figure out how do we get this information for med reconciliation and safety, to start identifying where the adverse drug events are happening in our system. Because again, the people who are not telling because they're at most fear for the stigma are the people that look like me, the people who are already being disproportionately impacted by health equity issues and biases in healthcare. And now we have this one new thing, right? And there is a risk for co-exposure. A lot of cardiac meds interact in a negative way. There's enzymes that we should know about that are fighting for the same receptors in our bodies. And how do we start to like guide the conversation towards they need to know, but how do we then ask them not to document it? Or how do we make sure pharmacy can do their job? So I keep bringing it back to healthcare because I don't think we have the infrastructure to support that reality. And from a legislator's perspective, what needs to happen for legislators to start to want to force us or to guide us to build this infrastructure? What is a like good beginning look like to you in this space?
Well, a couple of things I want to respond to, but it always comes down to descheduling is the safest and easiest beginning for us to build from the ground up. Instead, we are slotting cannabis into an already established system, and there already exists one with Schedule 3. And so by and large, as my limited experience working in hospitals, I am also just a person of strategy and execution. You build models based off of other models sometimes, and then you remix them. So I'm going to imagine that most people are going to start from Schedule 3 and then try to remix it up or down and good or bad, right, wrong, or indifferent in a way that they think about cannabis. I also think we have a mindset challenge. So even the way you're describing it, I would say the risk is not cannabis. The risk is a lack of cannabis education. And then I would probably want to, in the same training where we talk about adverse reactions, and I'm only saying this based on my own experiences in my family, make it such that the doctor then won't be the hater on the cannabis. Like, don't assume that the pharmaceutical is doing a better job at whatever miraculous changes you're seeing in your patient. That's where I struggle, because if there is an interaction or an issue, potentially even, sure, I want my doctor to know, and like any anyone else. I want the advice. There has to be some patient autonomy on the ability to choose what they think is going to work best for them. And right now, that's not what the situation is. It's very slanted. And if it's Schedule 3, it will be further slanted to, it's always then up to the clinician to decide what to prescribe. I mean, I personally am a negotiator with my clinician. If I know what works for me, you're not about to write that script on something that I'm not going to use. I'll tell them you're wasting your time. Yes. Because you can't force me to take it. But I think at the end of the day, that pushes us back to the illegal market, and that creates a whole different type of risk, and still hiding. So I wanted to at least address some of that, because I just feel like we're not ready educationally, and then there's the mindset. Those are the two biggest risks. Cannabis itself can be very harmless, especially when you start low and go slow. And so I think even having that mindset, we're not doing that. And you're right, adult use right now is not dealing with it as directly. I mean, in New York, they're not even allowed to deal with it, right? They can't say nothing. And I think that that's a mistake, because they should at least be able to talk about some of the things that they've heard, right, from their customers. Or even aggregate it if they wanted to do polling, like they used to do a lot of polling in Oregon. And that's how we know the top 3 reasons people shop adult use: for sleep, pain, and anxiety, in most of the mature markets. So just on that alone, I feel like more information should be coming from even the adult use market, but just isn't. And sometimes it's blocked. The last thing I'll say is health equity is defined in so many ways. And I think what it comes down to is, like, in the total, servicing of a patient, the total look, are we purposely or forcibly creating a dynamic where people have to hide parts of themselves, and especially Black and brown people, which, by the way, is akin to hiding that you could read. Hiding. I mean, I could put so many analogies to what has been multi-generationally instilled in us, that we are supposed to hide something. And I think cannabis just continues to fall in that box. And I think if we're going to really break out of it, we've got to break out of the societal based norms on, like, what's a good drug versus a bad drug. I know that there are already doctors talking about how we've demonized all drugs, and there's a lot of theory around it. But I think for now, cannabis can be harmless if we educate, and if we start from a little bit more of a tabula rasa. And I just don't know if that's possible at this point, after so many generations and decades of indoctrination on cannabis is bad. It's just hard. I'm not going to act like I have the answer, but I do think that's the piece of the puzzle: mindset, education, and at least willingness to get started with what we have, which now is Schedule 3.
Yeah, and that resonates with me deeply, because I often tell the story of moving to the United States in the 90s, where the DARE program was like front and center. And to be a good American transplant, DARE programs were like right in your face. Especially with the risk for immigrant families. Like, my mother was very much against drugs in the plant, because we would lose access to citizenship, and there could be deported. And there's been a lot of people deported for cannabis out of this country. And I think that that's something that why it continues to resonate with me in terms of the work that we need to do. And more particular, I like to try to leave people with maybe, like, what is the lowest hanging fruit thing that anyone can do? If you are in healthcare, I think the lowest hanging fruit thing is to just start talking about it, start asking questions and saying, hey, what are we doing about medical cannabis? Do we have education in the building? There's so many people doing education at the state level, at the federal level. I always recommend nursing organizations doing this work, because it's really important. And nurses touch every aspect of healthcare. We're at intake, we're at med reconciliation, we're at transfer, we are part of the social work care team trying to decide where you go after rehab, making sure you have education at home. And as you mentioned, I always say my mom is so lucky, because she has a nurse by her side. When she broke her leg and they were trying to send her home with Percocet, I was like, no, we have cannabis. And the doctor was like, actually, that's a better option. She's got less mobility, and it's less risk for constipation and all the other side effects. And there's and it was because I had the conversation. So I'm always encouraging clinicians, look things up, go on YouTube, tap into the weed head. Like, I mean, one of the first books I read about the business was your book, Dasheeda. It always stays right next to my table because it's important to understand what needs to happen for us to intersect with the cannabis industry as healthcare professionals. And I think education, you're right on the money, is one of the easiest things that we can do. The other thing I'd like to kind of put out there is how do we then interact with the medical treatment centers and the medical cannabis dispensaries in terms of communication? How do we hold them to the standard outside of regulation of being the teachers, the educators? They have the resources. How are they supporting and how are they going to use this 280E tax break to really support education of clinicians and really the integration of cannabis in healthcare? But I want to ask you, from your experience, what is something that anyone can do? What's the lowest hanging fruit action that anyone that is interested in this conversation can do today or in the next few weeks to really start moving the needle forward?
Great question. And I love that you plugged my book because I forgot about it, girl. And I will say that I got to get you the 4th edition to add to your library because the 4th edition is now available on pre-order at theweedhead.com. It's 100 pages longer, 100 pages plus longer, right? There's so much I learned in the last 6 years that I've now integrated into just, to understand the industry is really sometimes looking at the tip of an iceberg and just the desire to go deeper in your particular area. I happen to be one of those people who's a generalist, a strategy mind that can generally cover a bunch of different areas. So the book does that. But I would say you're right. Conversation is key. I used to say the lowest hanging fruit was hemp. And because we only have a limited time, I just got to say that fruit is being taken away. And the reason why I used to say it was the lowest hanging fruit because the hemp derived segment, although now having more THC related components, it was the breakthrough for the non-euphoric aspects of the cannabinoid plant. There is a lot of people, they say non-intoxicating or intoxicating. And because I don't, I know science cannabinoids are not toxins. I don't use that term, but I will say me and Dr. Rachel Knox, we settled on the euphoria because there's like different ways to experience euphoria. It can also be so euphoric that it makes you anxious and, feel very, very concerned. But THC really drives that based off of how it works on the endocannabinoid system versus some of the other cannabinoids are simply fantastic. And I'm not a big proponent of isolate everything, but hemp was at least getting us to those other cannabinoids besides CBD, which by itself is still an amazing thing. I mean, someone like myself, early MS, when I had to do COVID in Georgia, it was hemp-derived CBD that allowed me to still be walking, still be moving, still be doing all of the things and not have huge setback and deterioration from neuropathy to even not having good digestion because my smooth muscle is not working that well. That's all what CBD allows for in some ways. And so I kind of feel like right now, I would say another low-hanging fruit is don't go for the obvious with the THC. As you look at the cannabis plant, look at the other cannabinoids. CBG is amazing when I think about mood as well as just focus, but I call it the mother cannabinoid because it can transform itself. And CBC is also quite nice as well. And they all in many ways have anti-inflammatory properties. So you're never getting one thing in particular, actually still getting multiple benefits. But it would be nice if we didn't all rush through the door of this THC impact, not saying ignore it, but like look at the rest of the plant, look at the terpenes, in fact, and start helping us decipher what are all these amazing things in the plant that actually make it so fantastic, so that when and if we have a pharmaceutical framework, we're a smarter pharmaceutical framework, and it isn't all about THC pills, because that's where I feel like we're headed, and that feels like idiocracy for a plant that literally is a pharmacy on its own. So that's the low-hanging fruit. If you study it, if you are a health professional, if you are a patient, look at things besides THC and start talking about them and researching them and thinking about how they impact your body. And I think that would be a much brighter look at the plant itself and broader as well. And that's very low hanging. Hemp, unfortunately, is probably going away in October because of a federal ban on hemp derived. And again, this is all money moving it. So if hemp goes back to a Schedule 1, now it only still leaves the only lane as the state licensed medical operators. And even though hemp is quite big and quite white and male as well, they're fighting other big white male owner and operators on the medical cannabis side, and the patient is getting lost in it. So the last thing I will say is keep fighting for descheduling. It doesn't hurt us to ask for it every single session. To this day, we have the federal legislators still can change all of this by passing the MORE Act, or the Cannabis Administration and Opportunity Act. That's the Senate's version. And I know we have so many political theater acts going on, but at the end of the day, this is still how our government works. And so demanding it, making sure the people you're voting for are saying deschedule and not trying to be like, well, we reschedule it, so it's good. It's not going to be good. And we have to prepare for that, but we'll still fight for what we need.
No, absolutely. And I think you said it nail on the head. Like, the reason I created this series and wanted to have these conversations out loud is because a lot of our conversations behind the scenes sound just like this. We wanted to bring really the voices shaping cannabis healthcare policy to the forefront. And I am so grateful for this conversation. I think one of the things I'd add to your comment, if I may, is continue to grow your own medicine and protect home grow and protect our rights to access the way we want to access our medicine. You said this a few times, but it's a plant. And I think that we always say protect the people and deschedule, but we need to protect the plant as well, as we're entering a highly pharmaceutical space that is going to want to isolate and break down the plant for research for all these other reasons. And if I can add THCV there, because focus, that cannabinoid is magical, I believe. I honestly, I don't know what else to add. I want to give you a moment to, if there's anything else that you've left unsaid that you want to share with the audience today. This has been a great conversation. I love that a lot of the things that we're talking about and you're expanding on is some of the things that I put right in the book. I think we cannot manage what we refuse to see. And we need to make sure that we're looking at cannabis, even if it is just as a component of medicine, a Schedule 3 medicine that we need to just deal with. Even if you're just looking at it as, okay, this is something I have to deal with because it's creating a workflow interruption and some sort of liability for my healthcare facility. Just talk about it. I think we really need to just start talking about it. I also want to say, if this resonates with you, pre-order our books. These books are available. There are gifts to the universe as education, as resources. Dasheeda mentioned 6 years of additional information, 100 other pages. The first 100 were great. Having 100 plus more is probably so rich that it's gonna, I'm gonna have to go through it a few times. So I'm excited to get my copy sooner than later. But I'll leave it here with you, Dasheeda. Any last words before I close this out today?
Sure. Well, thank you again for having me as the inaugural discussion. I always love being the first, not gonna lie. And I think it's important to just reiterate that community-centered is patient-centered. Cannabis is inherently medicinal, and I'll stand on business on that every time. In the same way that ginger is inherently medicinal, there are some things that we just know about the plant, and we've known it for multiple generations. So, it's a good thing that the federal government has now caught up. But I do think it's important that if you're a health professional and or a patient, if you're both, even better, because you bring those perspectives to the table in a place where most people will like to deny their participation in the industry one way or another. And so I definitely want people to stand on business as a consumer, and also owning that there is some patientness in it as well. That's not a shameful thing. That's just how the endocannabinoid system works. But I'm just grateful. I'm also super excited that we're going to be joining each other in Boston on July 9th. So this book, the How to Succeed in the Cannabis Industry, the 3rd edition is available on Amazon, but the 4th edition is going to be supported by the State of Flower tour, which I'm doing with V, the Cannabis Traveling Writer. Yes, we're taking it through 10 different states, and of course we got to hit up Massachusetts, and of course I kind of was like, Drew, what we doing? We got both of us got books, so we're hoping to be able to share a little bit more in person, and hopefully you can join us there. But if you're not in Massachusetts, or you happen to be in New York or in Maryland or Pennsylvania, please check out theweedhead.com. You can find tour details there, and you can come meet me on the tour. Pre-order your book so that I can sign it for you there. But yeah, thank you so much, Drew. This is so critical, so important, and I look forward to just continuing the work. This is what we have to do.
Yeah, absolutely. Thank you so much, Dasheeda. You are wonderful. And I love that you were the first as well. Please make sure you pre-order a copy of Dasheeda's book. Please make sure you pre-order a copy of my book. Both links will be pinned in the comments. If you haven't already, subscribe to the channel, turn on notifications, and join us for the next conversation. Thank you again for being here with me, and I'll see you on the next episode. And we did it. We did it. That is awesome.